welcome you to the Reed and Christine Halliday Executive Lecture Series. They generously provide us many resources that allow us to carry on this lecture series, and we're grateful for them. Today we're going to hear from Rich Linder. Prior to founding Xenter, Mr. Linder served as the chairman or chief executive officer and/or vice president of several medical device companies. I thought if I read your whole bio, you'd have no time to talk, Rich, so you can go from there. Mr. Linder began his career in South Jordan at Merit Medical Supply, a publicly traded company. Mr. Linder is the founder and chairman emeritus of BioUtah, Utah's independent life science association representing Utah medical device companies, drug development, and drug discovery companies. Mr. Linder was appointed by the Utah Speaker of the House of Representatives, the governing authority of the Utah Science, Technology, and Research Initiative, or USTAR, as you may have heard it called before. Today, he is joined by several executives of Xenter. Will you please raise your hand? And a lovely daughter. And I think they'll be able to help you answer questions. He's brought several people, and sometimes at the end of this class, you'll have a question. But I fully expect at least 60% of you to have a job offer by the end of this class, okay? Just come up and see his people, and they're here to hire, okay? I'm lying a little bit, but if you're successful, you'll make that happen. Mr. Linder, please come to the stage. Please join me.
Thank you. Thanks, Tom. I love the enthusiasm here. It's palpable, it's tangible, and it's real, and it's something that I really enjoy. How many of you, I just want to ask really quickly, how many of you think you're a good student? Raise your hand. Okay. Might be honest, might not. Who in here thinks you're not a very good student, but you're really smart and you can get things done and you can get results? Raise your hands. Interesting. Okay. I was one of you. I was a horrible student. I was bored to death. If you could get me to class, good luck. I scored high on everything, and I scored really low on attendance. But I loved to play basketball and sports, and so I would always be at class. But I want to tell you something. You've got to find the ability to get results in your academic education. The best way to do that is by partnering with companies in experiential learning, where you can get internships, you can start on a career early, and you can gain some initial experience and relationships with people that will eventually trust you. The hardest thing that we have to find in our companies are people that we can trust, that show up, that will take responsibility, that will take initiative, and that will have loyalty to a company and the products and services that that company is providing. So the things that you're getting today, I'm really impressed that UVU is doing this executive lecture series and bringing people like me into UVU where you can talk to companies. And I encourage you to talk to companies all the time. And I brought some of the team from our company because I've done a few things, but they've done a lot of things. And I'd like to encourage you to speak with them. We have in here our VP of Organization Development, she runs human resources, but we don't look at HR as just HR. We look at HR as organization development, which is more. It's behavioral sciences, it's organization behavior. And if you've ever had an interest in that, that's Katie Patterson. HR is a component, and compensation and training and development. Those are some of the things that she does. We've got Scott Texley here. How many people in here have heard of Abbott? One of the largest companies in the world. Scott ran global PM or program management for Abbott everywhere on the planet. He also ran quality. So if you're an engineer who's interested in quality and regulatory, or in project management, or in program management, go talk to Scott Texley. So Katie, raise your hand, and Scott, raise yours. We have Robert Baxter as our Chief Business Officer. Who's eating at Five Guys? Blaze Pizza. That's Robert Baxter. So Robert, along with building restaurants, he owns 84 in the US and Canada, and internationally around the world, but has also developed real estate, commercial buildings, and other companies. So Robert, raise your hand. So then we have Tony Collins, who's our Chief Financial Officer. Tony and I worked together at Boston Scientific. So Boston Scientific had acquired one of my companies, and I was then at Boston Scientific, and we were the world's largest stent manufacturer. We introduced drug-eluting stents, one of the most important medical devices in history. You ever have anyone in your family have a heart attack? Well, they usually get a stent. We made those. We changed the world, literally. Tony ran all of Asia for a company called Guidant that we bought for $27 billion. Tony ran Asia. Lived in Tokyo, and then after that, he was on the executive team at Boston Scientific, and then he got stolen by the world's largest orthopedics company, Zimmer Biomet, where he was group CFO in an $8 billion company. So Tony, raise your hand. So now you have Brad Jensen. Brad was my high school quarterback. He was the president of our student body in high school, at Alta High School, and we graduated in 1987. And Brad became an engineer and then decided to go to law school and become a patent attorney. So Brad is our VP of Intellectual Property. He's been at some of the biggest firms out there. Brad, would you raise your hand? So these guys this team is a great resource to you. Go talk to them. Ask questions of them. Now, Xenter. This is a company that has some really big names on its board. Jim Tobin is one of the most successful CEOs in history. He ran Baxter, built it in the largest medical device company in the world, then went to Boston Scientific. And that's the guy that bought Guidant for $27 billion. He was also the CEO of Biogen, another important life science drug company. Elazar Edelman runs the Center for Engineering and Medicine at MIT. He's knighted in Spain. He's won the State Medal of Science from Israel. He is on FDA's advisory board and runs the largest center of institute at MIT with 1,100 people. One of the most important scientists at 16 at MIT, developing all the aerospace and satellite systems and communications for the Department of Defense. That was Elazar. Bob Langer is the most cited engineer in history. It's not, who you might think it is. His H score is the third highest in history, which means he's done more, the third most, to contribute to science than anyone alive. He's the co-founder of Moderna, which now I think he's worth $7 billion. Now, the thing that's interesting about Bob, he and I were on the phone the other day, lives in Naples, Florida, as well as Boston, hasn't sold a share of Moderna. We have a vaccine because of Bob Langer and the people at Moderna. So this is a pretty interesting board. David Beers, Mark Stopberg, Robert, these are some amazing people that I get to learn from. I want to learn from that board. You have then an executive team. John Wei Liu on the bottom left there, or bottom right, depending on your perspective, built Qualcomm, one of the top chip people in the world, semiconductors. Of the 10 successful microelectrical machine systems projects in the world, he did 2 of them. So John Wei runs our semiconductors. Now, you might be asking, what is Xenter? Is Xenter a semiconductor company? Is it a drug company? Is it a device company? Is it a data company? And my answer to all those questions is yes. Do you know, when we bought Guidant for $27 billion, it was part of Eli Lilly. It had been spun out of Eli Lilly. Why? There was so much competition for investment capital between the device business and the drug business. And remember, it takes $1.2 billion for us to get a drug to market. You wonder why it's expensive? Regulation. The immense scientific burden and regulatory burden that's placed on us in massive amounts of clinical trials. We don't like it, but it's something we have to do to ensure safety and efficacy of the drugs and the devices that we put in patients around the world. That's our job. And this team enables us to do that, by the way, and this is what I rely on in that process. And if I look back at Guidant and I look back at Eli Lilly, it made sense to take those businesses apart. It doesn't make sense to do it today. Why? Why would a drug company and a device company be together? I'm going to have to get in front of Wall Street next year and defend this to JP Morgan and Goldman Sachs and Morgan Stanley, and I'm defending it now. The reason is the way hospitals purchase products. They now have a thing called VACs, value-added committees. So they are bundling products. You don't just go into a hospital and sell a specific product. You want to sell a line of products, bundle them together, and do large purchasing contracts with these hospital systems. So Intermountain Healthcare is that way. HCA, Kaiser, there's a whole bunch, Providence. And we have to sell to many hospitals, not just one. Do doctors choose the devices and drugs that they use? Who thinks they do? Raise your hand. I didn't see a person raise your hand. You've trained them well. They don't, in large part. Someone makes that decision for them. Now, I don't know if that's good or bad. I won't even comment on it. I'm only going to say that is the current status of the healthcare system in the United States, and the rest of the world is moving in that direction. So, drug and device. Cardiac rhythm management, pacing. These are pacemakers that we put in the chest. These are important devices. There are only 3 companies that really deliver pacemakers to the world: Boston Scientific, Medtronic, and Abbott. Abbott just split its drug and device business into AbbVie and Abbott Vascular. But they maintain the ability to negotiate purchasing contracts. So they took their cardiac rhythm management business and bundled that device with the pricing of a drug, Humira, on an HCA contract, beating out Medtronic, who does not have drugs, and Boston Scientific, who does not have drugs. Now, these are hundreds of millions of dollars in contracts, maybe billions. So VACs are requiring us to bundle pricing of devices and drugs and keep these businesses together. Now, the other thing, we don't just treat a symptom anymore. We want to treat diseases. We want to go after heart failure. So if anyone is ever curious in cardiology, now, let me remind you, if you didn't know this, heart disease is the #1 leading cause of death in the United States. It is not cancer. It beats all cancers combined to kill Americans. And the #1 leading cause of adult disability is stroke. Most strokes are ischemic strokes, which means they're vascular related. It's all about the arteries that feed the brain and heart and provide oxygenated blood to those tissues to enable the brain to stay alive. If you have a heart attack, you have a blockage in a coronary artery. You have a stroke, 75% of strokes are ischemic strokes where you have a blockage in the arteries in the brain, or the arteries of the neck, the carotid arteries that lead to the brain. So that's the #1 cause of adult disability, stroke, and the most costly healthcare problem in the United States. So if for a minute you're thinking cancer is a problem, let me just put that into perspective. We are trying to kill cancer, we're trying to fight it, but heart disease and vascular-related atherosclerotic disease remains the largest problem in the world. So, What are we doing about it? We need to treat whole diseases. We've done so much on devices, on the materials, and on the drugs that we've kind of maxed out the things that we can do with them. So we need to bring these together. Chips, wireless systems, low power systems enables us to take these things and bring them together to create complex solutions to different disease states that we have not been able to treat in the past. So we need more tools. So what are we doing? Well, we're innovating and integrating data, devices, and therapeutic drugs to create seamless, novel treatment strategies for physicians and patients. Very simple. And the purpose is to enable personalized, targeted therapies through the acquisition analysis of physical intelligence and established digital biomarkers. All right, who can explain that? What did I just say? I know, every time, go ahead.
Taking a look at the way that data presents itself throughout the human body and then looking at ways to solve problems that represent themselves throughout that data.
Exactly.
Could you repeat that for the mic, please?
So he said, we're taking data and we're collecting data to solve complex problems. We're using data in analytics, machine learning, deep learning, representation learning to solve some of these problems. But you need large sets of data. Right now, the data is locked in an EHR. What does that mean? What's an EHR? Electronic health record. Every hospital system has a secure boundary-based system called an electronic health record. I call it Hotel California. Data goes in and it never leaves, if you're an Eagles fan, right? Because it's a locked boundary-based system. You can't get stuff out of it. It goes in, but you can't get it out unless you have permission, okay? And it's a data repository. Now, I have friends at Scripps in La Jolla. Scripps Hospital is just held hostage. Someone stole their EHR data from I think, Russia. They had to ship all their patients from San Diego and La Jolla up to Irvine to get procedures done. Shut down the healthcare system. That's kind of a problem, right? Data is locked, and if you lose that data, you can't access it. You can't treat patients. You can't even bring them into the hospital. You can't do procedures. So, we got to protect this data. Now, the problem is, if all of Southern California data is in Scripps and in Kaiser, but Oregon's data is in something else, Utah's data and Nevada's data is in Intermountain, in large part. And then you've got HCA, which has the eastern and southern half. How do you do clinical research? How do we get data from across the nation to give us indications of outcomes that will tell us whether or not we're doing the right things for patients in large scale? The answer is you can't. So this is a big problem. Now, the EHRs were built for reimbursement, for cost accounting. They were built to charge patients for procedures. They were never built for clinical research, and it started in the early 1970s. So since then, we have done such a good job in building the nation's and the world's healthcare and advanced it so far, we now have to solve that problem. Now, targeted therapeutics and personalized therapies. We gave lectures on this and talked about this 20 years ago. It never happened. We thought mapping the human genome would reveal all kinds of things, and it helped. We found things. But without being, it doesn't matter if you come in and I can study your genome, or we can study your genome or your proteome or whatever, and get your genetics, then what? Then what do you do with it? It's great to have the data, but what do you do with it? And can you match it to a specific disease? And can you match it to an outcome? Can you match outcomes to specific cells using digital biomarkers? That is the question in the future. So let me tell you what that might mean in simple terms. I'm a diabetic. That's a true statement. I am a diabetic. So if I have diabetes, one of the problems I have is keeping my feet perfused. In other words, the blood vessels in my legs, or in a diabetic's legs, can become weakened or occluded very easily, which means I can't get blood flow down there. If I have a sore on my foot, it'll grow and I won't even know about it. Eventually, you develop what's called chronic limb ischemia, or CLI. Well, we don't even know in CLI how to treat those patients, when to stop treating those patients. We can't tie tissue perfusion and oxygenation of tissues in the foot to blood flow in the legs, because we don't have the sensors that can give us the physiology outputs to measure flow by using pressure as a surrogate. And we can't put chips in the foot. Well, maybe somebody's trying to do that. Maybe we might be trying to do that. So that we can actually, for the first time, measure the amount of blood flow in your lower extremities, but tie that blood flow in an outcome measurement to tissue perfusion in your foot using a sensor. That's pretty cool stuff, isn't it? That's why we have to have semiconductors. So let's show you a little bit about this. We make drugs. We have a Aurora Gamma T IL-17 program on checkpoint inhibitors. I won't go into the details on that, because that just went over everyone's head. But I'll just tell you there's a big selling drug called Keytruda. $22 billion a year. Only works in 30% of the patients. That kind of sucks, right? I mean, if you need a checkpoint inhibitor, you need this drug, and I'm going to give you, let's say you're sick, I'm going to give you this drug, and I'm saying, take it, and it has side effects, and you may not like those side effects if you have them, and it's 30% chance it's going to work. And you've got cancer. If you can take that from 30% to 50%, we'll expand that market from 22 billion maybe to 35 billion. Now, these are big numbers. I apologize for the size of these numbers, but that's the size of the markets we deal with. We'll have outcomes in a phase 2 trial in our Aurora Gamma T IL-17 program that will likely show that improvement by the end of this year. And then I have a multi-billion-dollar drug. We like that. Our shareholders like that. What will we do with that money? Make more drugs. What are we going to do with it? We're going to make devices. We're going to make new chips and new wireless technologies. Now, what is physical intelligence? Everyone in here has heard of AI, right? Who's heard of PI? Anybody? Okay, this should be on a test. So, physical intelligence is real-time actionable data. Who drives a car with a chip in it that tells you if your car tire is flat? Yeah. Who drives a car that tells you whether or not your gas tank is full or not, right? That's physical intelligence data. It's real-time actionable data of what's going on inside of a system. In that instance, it's a car. In a human being, it's what's your heart rate. It's what's your glucose level. I'm a diabetic. It's your oxygen saturation. It's your red blood cells. It's your hematocrit. It's your white blood cells. It's a tumor. It's the presence of a disease or not the presence of a disease. That's physical intelligence data. PI data is the most valuable data in the world. And right now, companies are fighting to obtain it, to generate it, and to control it. And then you do AI on PI data. That's where we're going. That's what the future of the world is. The most valuable businesses in the world in the future will be those that can obtain and build products that obtain PI data and then provide it to users, to consumers. to patients in our instance. So if you do analytics on bad data, you have bad analytics. I mean, it used to be companies would come out and they'd say, we're an AI company, and they get high valuations. I mean, just for saying we do AI. I have to tell you, I don't give a flying rat's butt if people do AI. If they aren't doing it on the right data, if they aren't doing it on the right PI and real-time actionable data. So, we're building that system in 3 business units: medical technologies that builds devices and sensors, and we have therapeutics, which builds drugs, and then digital technologies, which is all about the data. And then what we do is we build smart devices that are wireless, that collect PI data that becomes actionable information for the design of new medical devices and procedures. We then take clinical trial data and data from those smart devices and use it as actionable information for the development of new drugs. You may have noticed, if anyone did their homework on Robert Linder, if you're fast and looked him up, he's the world's nanoparticle expert. We have a project in nanoparticle where we're actually taking nanoparticles to deliver drugs. Did anyone know that we have 2 vaccines that are both nanoparticle-based vaccines? Did you know that? It's pretty important stuff. Novel drug discovery is all about obtaining these digital biomarkers in our cloud, which will be a global healthcare cloud. And I have to worry about protecting that. I have to keep out China. I have to keep out Russia. I have to keep out Iran. So if you're going into cybersecurity, good for you. Because we need people that are the best at that to protect these data sets. And we're taking all this cloud to find new patient populations with poor outcomes and connect those outcomes to novel biology using data. So that enables us to do this. We can get the right drug into the right hands, into the right patient, and hopefully take that 30% response rate to 40 to 50 to 60 to 100%. Because I was a patient. I've already built several companies and sold them. What I'm doing this for is because I laid in ICU and I was told I wasn't going to live through the night. I have a daughter here who was in a hospital room where I coded. Code blue, room 14, 12, whatever. That was me. She ran out with my wife and my 4 other kids, and all the docs ran in, and my heart rate went to 0. But I lived through that. Then they sent me home on feeding tubes to die. And I just happened to live, to the surprise of everybody. I now have no pancreas, no spleen, no gallbladder. And I'm on a continuous glucose monitor and about 17 drugs that keep me alive and allow me to eat and drink and process food and digest. It's pretty bad. So am I motivated? That's why I'm doing it. I don't want you guys to go through that. That sucked. I want patients to get well. It's not about money. If you think it is, you are wrong. And we're looking for people who want to make a difference in the world. Yes, money comes, it takes care of itself. But those altruistic motivations of wanting to become the best that you can become and to help other people and to give back, that's what I'm looking for. Now, this is a cardiac cath lab. We're going to change that. We're going to have new wireless technologies, new chips that enable us to do more with data. We just came up with the way to put on a 0.014-inch coronary guide wire multiple chips. No one's ever done that before. And then we can do this. This is the left anterior descending coronary artery with 2 atherosclerotic lesions. That blue lighted up section on a wire that's only 3 times the diameter of a hair, has chips in it. Now we can tell you the pressure in that coronary artery, and we can tell you a flow reserve. You want it to be above 0.89. Wow. If we stent that lesion, we find that this lesion here was the culprit lesion. Let's see, is this working? Kind of well, it doesn't show up too well. But that first lesion is the culprit lesion. If I were treating with angiographic imaging alone, which is real-time X-ray, and the injection of contrast media where I can see it, it shows up on X-ray, I would have stented both those. I would have put a $1,000 stent in both those lesions, and the patient didn't need it. I can stent one and put that patient on medical therapy, not worry about the distal lesion or the second lesion, and it's better for the patient, and it's better for the healthcare system, right? Because we're making better choices. That's PI data. That XFR score, that's PI data. That's physical intelligence real-time data. It enables a doctor to make a clinical decision. That's the information we're wanting to get and store. Now, on that bottom left, you'll see a long catheter hooked up to a cable that's hooked up to a cart. That catheter goes in the heart, goes in the middle of your heart. Well, isn't it sterile if I'm sticking a catheter in your heart? That's got to be sterile. But that cart is sitting out in the hallway in a hospital collecting dust, and I have a cable there. All that stuff has to go away. It takes 15 to 30 minutes to hook up that cart to that catheter, but I only have 90 minutes to get a patient from the door of a hospital, if they had a heart attack, into the cardiac cath lab, through the ER, into the cardiac cath lab, and put a balloon up in that coronary artery and put a stent in there to restore blood flow to save that life. I'm not a doc, but that's what the docs do. Am I going to take 15 to 30 minutes to hook up that cart? 83% of patients in the United States do not get that, even though outcomes have been increased with the use of that catheter. This isn't just one company. This is all companies that have this problem. So if someone could actually take that catheter and eliminate that cable, because then I don't have to have 2 nurses come in and bag that cable with sterile bags, so I can connect that catheter into your heart, that'd be really big, say 15 to 30 minutes. So we did it. Now what you've got is, on the right, new chips in a no prep, no time, no cart, no cables device that goes into your heart or your brain or your legs or your kidneys or whatever, wherever we want to put it, and no prep at all. Take it from the package, sterile pouch, put it in. I mean, it might be 10 seconds, 20, 30 seconds. So in Japan, by the way, intravascular ultrasound, which is the name of that catheter, is used 95% of the time because they are forced in their healthcare system to get better outcomes. Here, it's not the same. You leave it up to the docs, and they never use it. It's all about time and hassle factor. Ease of use wins every time. Make products easy, guys. Whenever you get into your jobs, make things easy. You will kill it. You will win everything. Cut steps out of it. Get things done faster. Make it simpler. Enable faster decision making. That's the name of the game. That's what this does. That'll generate $1 billion in revenue one day for us, we believe, once we get that throughout the world. Now, I love it because it can generate this image. No one has ever been able to do tri-registration of various different imaging and pressure modalities in humans to generate that image. I just came back from Miami and Boston. In Miami was the International Symposium on Endovascular Therapy, where I showed this screen to docs who said, this is like Disneyland. This is the Holy Grail. We've been asking for this for decades. You mean you can take angiographic imaging plus that intravascular imaging of a 10-centimeter section on the bottom right of an artery, and then map a continuous pressure gradient right above that to tell us all the data that we need? Yep, we can do it. We'll launch it in probably 18 to 24 months, and it'll change how we treat patients globally. All that, by the way, is being done here in Utah. You don't have to go to Boston. You don't have to go to San Francisco. Our facilities are right up the street. So this is the stuff that we're doing in Utah now. Now, we also build that global healthcare cloud. Do we do AI? Yeah. We do machine learning all the time. Tony, we're about time out. So I'm going to end with this. Who in here, I gave a keynote address with the Secretary of Health and Human Services and Clayton Christensen, who's now passed away. Anyone know who Clayton Christensen is? Wrote Innovator's Dilemma, Innovator's Solution, Disruptive Technology. One day we ought to talk about disruptive technology versus destructive technology, continuum-based markets versus cyclical-based markets. Clay and I were going to publish this. We never got to it. He had a stroke and passed away. But I have to tell you, that guy was amazing. What a loss. One of the greatest minds in business that we've ever had, professor at Harvard Business School. Well, I have to tell you, disruptive technology requires a certain way of thinking. Destructive is another. Think cycles versus continuums. I'm just going to give you a little hint. Continuum, cancer. Cancer. You either have it or what? You don't. If I eliminate all cancer in you, do I need additional therapies later if it never comes back and it's gone and you're cured? You can't have negative 10% cancer, right? There's a 0 and a 100. There's a beginning and an end in medicine. In mobile communications, that is not the case. That is the exact opposite. You have cycles, and you have continuing types of technologies that are being developed in these markets that continue to hit these markets, and companies come and go in those cycles. And as technology shifts, you kind of shift the railroad tracks and the train from one set of tracks to another. That's disruption with a completely new technology that nobody else really uses the old technology. They use this new disruptive technology. But the need for mobile communications keeps going. And I can have additional technologies that come along that shift the railroad tracks yet again. That's disruption in a cyclical-based system. Destructive technologies are those that own the continuum and nobody else can ever compete on it. So if I have a technology that gets a disease from 100% down to 50%, and then people are getting all these incremental advancements down to 0, wouldn't it be better to just develop 0 at the beginning and do it right up front? And own the continuum so nobody else can beat you ever? That's destructive technology in a continuum-based market. And I can come back and talk about that later. But let's open it up to some questions.
So with the various projects you guys are working on right now, at any given point, how many projects are underway, and then how do you guys decide how to allocate resources towards those? Okay,
so each project needs to be independently evaluated and sourced, resourced, and you need to keep people out of working on the same projects. And you need to not hold these people accountable for what these people are doing and so forth. So we'll have, for example, we have, I'll just take the medical device business. We have a lot of different projects, and they're usually, we put them on as usually a product. So we have a GuideWire, a SmartWire team. We have a Smart IVUS team. We have a chip team. And all these people work independently, but then they also have to work together. The way that resources are allocated is at the board level. And the board sits down and says, what do we need to build a EBITDA of whatever and hit a revenue line of whatever in year whatever? And you'll have a list of products that you're evaluating that'll get you that revenue line. Now, when we were in big companies, we used to cut, if you had 15,000 SKUs, single kinds of units, you'd cut the bottom 10% every year. And you do a product review, and you just jettison those products and programs because they're not returning for you on time. And that's something that we do continually. So, and Tony, did I say that right?
No, that's good. The only other thing I'd add is there's also a risk element to it, right? So we want products that are low risk and then some that are higher risk. And so we're looking at that continuum. We graph it, along the trajectory of higher risk to lower risk and return on the other axis. But no, that's...
And there's some IP issues, Brad.
Right. We have to know that we have a path to do what we want to do, because there are competitors that have gotten patents or they have ways of blocking us, and so we have to make sure that we have a pathway to do what we want to do.
And we look for a thing called FTO, which is FTO, freedom
to operate.
So Brad's always looking, he wants everything to have freedom to operate and then what I call APC, or the ability to prevent competition. So offensive and defensive patents. So.
Thank you.
Anybody else?
How did the shortage of semiconductors affect your business?
Oh, goodness gracious. All right, so the world's largest chip manufacturer is TSMC, Taiwan Semiconductor and Manufacturing Corp. Samsung's number 2. So more than half the world's semiconductors come from Taiwan. Are we worried about that right now? After Joe Biden was elected, China sent a carrier group through the Taiwan Straits. I had dinner with John Kelly, General Kelly was the chief of staff for President Trump. Whether you like President Trump or not, I don't care. I'm not into all that, I'm not a politician. But what happened was, for some reason, China felt like they could move a carrier group when we changed presidents through the Taiwan Straits. John was working to get a non-nuclear submarine to patrol the Taiwan Straits. And Taiwan might have that now. I don't know, but I suspect they do. So that would be a deterrent to military aggression from a carrier group. But the Air Force in China is big. So we're worried about Taiwan. We can't lose Taiwan. So the government had TSMC build a plant, $18 billion facilities going into Arizona. And I think it's TI that's building a $17 billion, or Samsung's building a $17 billion in Texas. So the problem with supply chain is real. There are risk elements, and every time you disrupt that supply chain, it really screws things up. And people think that they can increase production quickly. You cannot. You have to reach equipoise, and there's a balance that you reach in distributed supply chains. And if you can't reach that balance, and you have significant disruption like COVID, and you shut down ports, or you shut down rail, or freight delivery, that equipoise is gone. You cannot fix that in a month. The government reacted, and I have to tell you, I do sit in meetings where we're talking about some COVID policy with FDA and CDC and everything. You'll probably see a easing of mask restrictions in the spring, and people will stop talking about masks. Okay, that will probably happen. We actually have no randomized clinical data on mask wearing. So the only randomized clinical data we have on mask wearing is it's not effective. I'm just telling you that. And when Tony Fauci sat in a room and came up with 6 feet, it was in Atlanta, and I know the guys in the room, and Tony said, well, we got to keep people apart. We got to keep people away from each other. Can we do that? And they said, well, how far? Well, maybe 10 feet? I don't know. And then it got to, well, I don't think we can keep people at 10 feet apart. Maybe 3. That sounds good. And then it was 6. That's how you got 6 feet. We can't do the clinical research that fast. But that impacted the supply chain. And companies shut down workers, and people started staying at home, and then the world changes. And now, here's where we are. We got to fix that. My frustration? People don't work together. Politicians aren't working together. We got to fix that.
There's about 50 watching online today, Rich. One of the questions from them is, okay, you're developing this, you get it in the hands of the hospitals or other medical providers, how do we get it to the end user?
So we usually do that. That's a great question. How do we get to end users? Hospital contracts. We call it call points. So we'll have a direct sales force in the United States and North America, Europe, Middle East, Africa. We'll use a direct sales force in Japan, but they work with large hospital contracts through value-added committees, and we sell into those contracts, and then we supply directly to hospitals. And then in other countries, we'll use distributors. India, Latin America, South America, things like that. Other questions?
We might have time for one more.
So for a young person trying to get into the industry, what would you say the best way, in our shoes, graduating soon, what's the best way to get into this field of medical devices?
So what's your degree in?
Well, mine is healthcare administration.
Okay. So let's say you want to go into med device. You usually would say, I'm going to pick a particular career within med device. I want to take an engineering route, or a quality, or a regulatory, or a sales, or a marketing, or an accounting route. The administrative side in our business usually comes from people who rise through those organizations. Katie, is that a good way to put it?
Yeah, I think the other thing you guys could do as students is reach out to companies. LinkedIn's a great way, send HR messages or to the CEO to say, this is what I want to do so you can get internships. Internships are huge. As we bring people in, they learn about the organization. We want to keep those people on board and grow them within the organization for sure.
Can we thank him for coming?